Here, it's not a big bottle, it's a short bottle. And I got a It's everything about this picture.
Alright, I think most everyone is back, so we're going to go ahead and get started. So what we're going to do for neural tube defects, we're going to do an ongoing case study as we go through the lecture, just to make it a little more interactive. There's a camcorder over there, sorry, I have to record it for my class that I'm in right now. So we're going to break up into groups. If everyone's here, it's going to be 6 groups of 6 and 2 groups of 7 for the case study groups, and that'll be throughout the slideshow. So if you'll break into groups with people sitting around you, okay? There should be 8 groups. Okay, so yeah, 6.
Y'all group up and move together so we can see.
6, perfect. You're good. Okay, so Noel here. Okay, perfect. Okay, so during this presentation, we're going to talk about varying types of neural tube disorders, and there are some pictures on here of what a neural tube disorder looks like, and some of them are a little bit graphic. So just to prepare you for that. But then also, a good thing to think about when we see that is if a mom or a dad, if parents have a baby that has this and they see that, think about what the parents might be feeling, how we might need to support them through that, okay? All right, so just a brief intro on neural tube disorders before we get into the first case study question. It is the largest group of congenital anomalies. In a normal baby, the spine and the spinal cord and the cauda, all the meninges, are encased, and all the what's the word I'm looking for? The neural elements are encased into that protective sheath that has bone and meninges. But with these babies, there's a defect in that. And so it could involve the entire length of the spinal cord and neural tube, or it could just be a small portion of it. And their prognosis is going to be dependent upon how much is included in that defect. It happens in girls more than boys. It happens 3 times more often in Caucasians and African American babies. And it is one of the most common birth defects that we find in the U.S. So, let's start with our first question on our case study. We have Miss Ashley. She's going to be the patient we're working with. She's a 32-year-old female. She's 17 weeks pregnant right now. She has a history of poorly controlled type 2 diabetes mellitus, and she has not had any prenatal care up to this point because she didn't know that she was pregnant. So the doctor decides that we should screen Miss Ashley's baby for neural tube defects. So get in your group and be thinking about what is the pathophysiology of these neural tube defects and what contributing factors that we know just from Miss Ashley's history might contribute to them. All right? All right, everybody feel good with their answers they've got? Thought about it? Okay, let's start with our first group over here. What'd y'all think? What'd y'all say with the pathophysiology?
She had no early prenatal care, so she may not have had folic acid.
Yep, that might be some of the contributing factors. What else in her history might show us?
Diabetes and obesity.
Very good, very good. And without the prenatal care too, she might have a lower B12 status as well. So what would someone define as the pathophysiology? Just a nice textbook definition of neural tube defects. So that's the cause. So what it is, it's the, failure of the neural tube to close. That's all we would call and the pathophysiology is, it happens during that embryo's early development. Okay? And that's between 3 to 5 weeks. Good job. So we talked about that. One big process that goes a lot of times with neural tube defects is hydrocephalus. And y'all talked about that in your lecture last week, right? And so this is in 80 to 90% of these babies who end up having neural tube defects. So we think about all the associated issues with that too, the ventroperitoneal shunts. Did y'all talk about those last week? So that's just something to keep in mind when we're thinking about a child with a neural tube defect. So the cause of it, there can be a lot of causes. It could be maternal drug use, mom being exposed to radiation while she's pregnant during that 3 to 5 week period, mom being malnourished, any chemical exposure. It could be just a genetic mutation in those folate pathways so that folic acid is not making its way to the baby. And then it also could be syndromes such as trisomy 18, that can be a cause for neural tube defects as well. And then y'all did a good job talking about this mom, Miss Ashley's factors. Obesity, uncontrolled diabetes mellitus is a big contributing factor, low B12. If she had maternal hyperthermia during those 3 to 5 weeks of development, and then also if she had to have an AED used on her during pregnancy, during those 3 to 5 weeks. All right, back to Miss Ashley. So what diagnostic testing will be done to rule out or confirm a diagnosis of neural tube defect in her baby? So what are our diagnostic tests for this, and then what will those tests show? group in the back? Right, yep. Whichever groups, right, yep.
Us?
Y'all can do it, yep.
We said elevated AFP test
Perfect.
and a urine ultrasound.
Yes, perfect. So that's exactly what we're going to do. They're going to have the AFP, and AFP, alpha-fetoprotein, is a normal secretion by a baby. And normal, like low amounts in maternal blood is normal because some of it will cross the placenta. When mom's blood has a high amount, that's when we might be thinking there's some leakage of some neural factors and things like that into the amniotic sac. So then if we find that, we're going to go in and do, they'll do a amniocentesis, and they'll see what the levels are within the amniotic sac. And we can also do a uterine ultrasound, and that'll show us the extent of the lesion, where it's at on the baby's neural tube, and we can go from there. So with these babies, termination is an option that the doctor will often give the mom. It can be done anywhere between 20 and 24 weeks. So just something to know when it comes to supporting mom, that is a lot of times an option they'll give for these babies. 20 to 24 weeks. So, various types. Now we're just kind of going to do an overview of some various types, talk about a few of the ones that your books talks about, and then we'll get back into our case study a little more. So this is just a list of some of the types that your book talks about, and let's move into the first one. So exencephaly is where we have the brain totally exposed through a skull defect. And these babies do not have a good prognosis at all, as you can probably guess. But they do sometimes have their brainstem still intact, which means their breathing and their cardiac function can be okay. So sometimes they will live a couple hours to a couple days. But this is not a compatible with life neural tube defect. Our next one is encephalocele. And so this is where the brain and meninges come out through a defect that's in the skull. And with this, they do actually have a better prognosis. If the defect's in the front, then they have a better prognosis than if the defect is in the back. They'll do a surgical closure of this. The issue comes with this one, aside from having neural tube particles in a sac on your brain, on your head, is that a lot of them have other associated defects with it. They might have syndromes, they might have genetic mutations, and that decreases their chance of survival if they have any of these associated anomalies. And then anencephaly. So this is where a baby is born without either of their cranial lobes, cerebral hemispheres. So they also have their brainstem present a lot of times. So these babies can actually live a few days to a couple of weeks, but they don't have any brain function aside from brainstem function to keep them going. And usually they can keep up, like we said a minute ago, that cardiorespiratory function, but they'll eventually die of respiratory failure. So now spina bifida. So there are two types of spina bifida, and this is what we talk about when we're talking about the neural tube closure, when we think about it on the back, and that is spina bifida. So there's two types. There's spina bifida occulta, which is where they have a neural tube defect, but it's not visible on the external part of the baby's body. Or there is spina bifida cystica, which is where there actually is a defect, and this is what a lot of times we end up seeing in the hospital. So occulta, this is where we're inside the body. It usually happens in the lumbosacral region. It, a lot of times, they even call it hidden spina bifida, or not even a true neural tube defect, because sometimes they don't even have any signs of it. But if they do have signs, it's going to be a skin indicator, and it'll be a depression or dimple, so you can see that on that picture on the left. They'll have a little dimple on the back of their sacrum. And with every new baby, that's one of your new baby assessments, is you're going to check that. Because the mom might not have known that she had that with this, because there would have been no symptoms that led her to it. And then they could have an angioma or a port wine nevus on their sacral region, as you can see in the other picture. They can have sacral tufts of dark hair, and it's very interesting phenomenon, because you turn a baby over, and there's just a tuft of really, really dark hair right on their sacrum, right where that indention is. And then They also can have little lipomas under their skin, which are just little fatty pockets in that sacral region as well. So, these babies sometimes don't have any type of neuromuscular disturbance. But if they do end up having a disturbance, then it's usually a progressive disturbance with foot weakness. So you'll just notice one of their feet is having some weaknesses, and that'll progress through their life. Or they might have bowel and bladder sphincter disturbances. So they might have issues with continence, with retention, and we'll talk about that a little more later because that's a lot more common with our external defects. So cystica, these are our external defects. There are two types of this as well. There's meningocele and there's myelomeningocele. And these can be anywhere on the column, so they could have a high defect, they could have a low defect. And it can be diagnosed prenatally like we talked about earlier, but some people might not have those diagnostic measures taken, and so they might find this at birth. So,
But no matter what, wouldn't their beta protein be high?
it would, but we're not always observing for that so much. And if there's not any leakage, it might not be as elevated to make you worry about it. But usually it should be found on an ultrasound. If they have a big external defect, it should be found on a well-baby ultrasound. So, meningocele. The difference between these two is what the sac contains. So with meningocele, it holds meninges and spinal fluid, but there's no neural elements in it, no nerves. And these babies oftentimes won't have any neurological deficits after they have closure surgery. They might not have any neurodeficits. But they might still have that bowel or bladder dysfunction that we talked about a second ago, and then they can have some paralysis. So myelomeningocele is where our sac contains meninges, spinal fluids, and nerves. And this is what is clinically classified. When you hear the term spina bifida, that's the clinical classification of myelomeningocele. And this often has a lot of neurological deficits, a lot of paralysis issues, and things along that nature because those nerves are in the sac. Yes, ma'am?
Like the surgical procedure, like after the surgery?
Mm-hmm. Yeah, so that looks like a smaller one, and then that's a very large one right there. But yes, and then they'll have the surgical closure to close it in on there. Okay, so I included this on there, and you should have this on your slides as well that Ms. Osteen sent you. This just gives you a good representation of what the differences are. So on the first one, up here you see the normal vertebra, and then you see the occulta where it's stuck on the inside, and I don't know if you can see that closely, but they even put little tufts of hair on the outside of the skin right there. And then we have the meningocele, which is where it has just the spinal fluid and the meninges, and then we have the myelomeningocele, which has the neural elements in it. And then the last one we see a rupture. So, and we'll talk a little bit more about rupture in a minute. All right, back to Ms. Ashley. So upon amniocentesis and ultrasound, the doctor finds that she does have spina bifida cystica. So which one is that, internal or external? External. Good job. So now just break into your groups, and we're going to talk a little more in detail. What are the two types of cystica? And then think about what clinical manifestations you might see with it. Okay?
Oh, Austin, that's really it's not
When we're thinking of clinical manifestation, think about where on the neural tube this might be happening, and then think about what that could mean for the baby if there are nerves being pulled outside the body. I don't know if y'all thought about that, but just a little more clarification on clinical manifestation. Are we all good? Okay. All right, do y'all want to answer this one for me? Group right here?
We said that sometimes that could cause us to have like a lack of like bowel control since it is like there.
Go ahead, and then, oh, go ahead, what?
Allows to have a negative thing.
Well, because the baby's in utero, obviously, so, they would have the contractors, the kyphosis, the lumbo, scoliosis, and the hip dislocation.
That's right. And then, someone tell me a little bit about the difference between meningocele and myelomeningocele one more time.
Meningocele is just the fluid and energy, so there's no nerve involvement, and then the other one has nerve involvement.
Good, exactly. And then, one more thing to think about. If there's nerves being involved, there's one more clinical manifestation we might see. Yeah. Yes, paralysis, exactly. So, good job. Okay, so we kind of talked about all of this, but one thing I want to elaborate on is wherever that neural tube defect is on the neural tube, you're going to have partial to complete paralysis below that. So if we think about it, where would be the worst place on the neural tube to have it. Yes, the highest. Just the higher it is, the more loss of function you have. So we can get the partial paralysis. Sensory deficits is another thing they can have. And this is like not being able to know. You've heard the stories of people placing their hand on a burner and not even feeling themselves burned. That's the type of sensory deficit you might see with these kids. The urine and the bladder and the bowel control, that is another. They can have either dribbling, constant dribbling, because they don't have that sphincter control. But they also don't have the ability to sense when their bladder's full. So although they could dribble, they could also be retaining it as well. So eyes and O's are a big thing that we assess with these babies to make sure they're getting rid of their urine. Same with the bowels, so they can have anything from constipation to diarrhea, just because that sphincter is not as developed and they don't have the neuromuscular capabilities. So we want to make sure they're always on a good diet, high fiber diet, or that they're getting some type of softener if they have issues with constipation. So that's just another constant assessing. Yes, ma'am?
So these are the manifestations for both of them?
It is, yes, but the myelomeningocele is where you see these most often.
Okay.
With the meningocele, you might see some bowel and sphincter issues, and then you also might see some paralysis. But when we're talking about these bad symptoms, these bad clinical manifestations, that's the myelomeningocele. Yes.
Now, once they, do the surgical procedure to remove it or whatever, like, what's the, recovery?
So we're going to get into that too. But these babies, I'll just tell you a little bit now. So these babies are going to be in the NICU for a while. We're going to be monitoring their function. But any issues that they have prior to closure, or once that neural tube defect is formed, it's going to be a chronic thing they have. So they don't regain function from that. We can, like with the bowel and the bladder function, we can do therapies to try to help increase that. But the paralysis and things, those do not improve.
That's why you give you the option to go in and turn the child.
Exactly. Exactly. So, these are just some information about where it's located. So if it's below the third sacral, if it's low, they might not have motor impairments, but they could have just saddle anesthesia, which think about if you're sitting on a horse on a saddle, it's just in that area, so the bladder and the bowel. So, and then, like we talked about up here, they can get joint deformities when they're in utero. So, good job on talking about that. All right, back to Miss Ashley. So this is a little more a nursing support question. So she's visibly upset and she begins crying because she found out her baby has myelomeningocele. So what are some ways that the nurse can support her now that she's learned the diagnosis, and what kind of support might she need for the rest of the pregnancy? So just be thinking about those supports that we can give her and just come up with a few answers to that.
means we're doing a support.
Do you feel like he might get fined?
Thank you.